Thank you all very much. Thank you all that have stayed on the Zoom through this whole session. Um, In a couple of minutes, we're going to go through the distillation of all the discussions from the two breakout areas and have a chance for any other additional comments. Before we get into that, though, it'd be important for us to acknowledge the fact that we're here because of the sponsorship of ALA and Prevent Cancer Foundation, which have been gracious hosts through this entire process. We thank you very much. We thank all the staff for not only executing this great forum, but also doing all the stuff in the background that allowed us to have two very, very productive days. We thank the technical people from Blue Ridge that have been able to help us through this communications across the world. I don't know how many countries have been involved in this Zoom cast, but it's a lot, and we appreciate that it was able to flow largely effortlessly. And we now come to the time where all the work of the presenters and discussants is going to be synthesized. And to start with that, we have Raul Estepar, and by the wizardry of the information systems, we'll have our good colleague Sean Fain. And I think Sean is going to lead the discussion of the distillation.
Yeah, that's correct.
Oh, thank you very much, Sean.
So this is the breakout that we had discussing the accelerated progress in treating pulmonary disease through innovative clinical trial design. And this was a group of about, I think we had about 20 or so, maybe a little bit less on the discussion, but it was core experts who have experience with lung imaging and development of imaging biomarkers and how they are applied for progression of lung disease. The first topic, in general that we had in the discussion to set the context was, what is the role for imaging endpoints for monitoring and therapy response, and biomarkers for disease dynamics and treatment efficacy have been utilized, for a while now, but, we're sort of trying to look at ways that we can intervene at an earlier stage and use these as tools for developing treatment approaches in pharmacological trials at an early stage in the disease process. We pointed out, based on discussion that occurred previous to our breakout regarding the role of AI, that AI can probably play a direct role in this type of application by sample selection, in that it can identify potentially endotypes of lung disease that would be more likely to respond or be treated by specific interventions. During the general discussion too, we were struck by Dr. Yankeliewicz's comment about biomarker effectiveness, in particular, the statement about the balance between accuracy and decrease in prognosis, which really highlights the point about biomarkers being the key fulcrum here in terms of their accuracy and precision. Also, the points about reducing costs. So anything that we would want to contribute in this domain would hopefully reduce cost and find the signal, in essence, make it actionable and clinically meaningful. We also pointed out that at the present, in the context of previous discussion, there's a lack of qualified image biomarkers from the FDA standpoint for trial implementation. So how can we perhaps utilize this earlier detection of disease through the lung cancer screening as a way to validate some of these biomarkers? The other point that came up that I think was really a visceral point was flipping the iceberg concept that, this earlier detection and intervention is really a way to address the disease process before it progresses to severe outcomes that cannot be reversed. So lung cancer screening offers this potential in early phase trials to help define the mechanisms of action through imaging specific biomarker responses. And since there's serial imaging built into the lung cancer screening participants, this technique can help open the door for developing imaging endpoints for monitoring response as a kind of freebie, if you will, as a follow-up. clear opportunity then to improve airway disease assessment and lung cancer screening. And again, AI could help to find better airway-specific biomarkers. And this gets at the concept of endotypes and remodeling and mucus plugs as potential biomarkers for endotyping, for example, type 2 inflammation. So we had three kind of topics that organized our discussion. The first of those that came up was population health. And this was in the context of using quantitative biomarkers as a way to communicate to patients where they're at in the spectrum of their disease and help perhaps to encourage them to pursue healthier lifestyles. And in that discussion, Chuck had mentioned the project he had with Milan Han showing a report to patients with COPD to encourage them for smoking cessation. And he made the point that images, in effect, played a secondary role in that study, even though they had a very positive measured outcome of inclination to quit smoking in those patients in the intervention arm, that by and large, it was mostly the report out of the clinical data and the intervention of personal interaction that probably drove that. So in that regard, we essentially left as potentially helpful this kind of tool to provide a clinical report to the patient, but maybe isn't the sole focus of our effort here. So the second thing we discussed was de-risking pharma trials. So using image biomarkers for better endotyping, which I mentioned previously, the hope is that this can enable more effective trial enrichment strategies. Quantitative imaging can also serve, and this was mentioned in a specific example, to provide a deep phenotyping tool for focused mechanistic trials that can prove the concept of an intervention. And an example I could think of here would be the way that the mucus score evolved out of, the asthma trials that I was involved in. And this now has been utilized as a kind of mechanism or a surrogate mechanism of that improvement in FEV1 that we've observed with the type 2 therapies. So this sort of opens up the door for interpreting what the spirometry improvements are meaning in the context of a specific disease endotype. And then the other discussion we had was around phase 4 clinical trials, where pharmaceutical companies are interested in expanding indications for their currently FDA-approved therapies. Dupilumab would be an example of that, for example, and other type 2 inflammation targeted therapies in COPD. So we then discussed implementation of these approaches. One of the ideas that came across was this consortium model, where one construct would be to have expert centers, because it's probably unlikely to, easily disseminate consistent protocols harmonized across centers in a larger scale. It might be possible in this more focused scale across expert centers with high volume lung cancer screening, where those centers could be chosen to capture a range of unique and diverse patient populations. And then we would implement and maintain these quantitative protocols across those centers. And then that would help enhance patient selection and accrual. And this could be a consortium that would advertise itself maybe to the pharmaceutical industry, so that we would be, go-to network for this kind of application. And then, although it wasn't a extended discussion, we did mention models for adaptive trial design. So these have been successful in oncology, and it's challenging to see its application in chronic respiratory conditions due to the limited therapeutic landscape. But because we're talking about early interventions in this case, it's possible that we could identify a set of low risk, high reward therapeutic types of interventions that might be, useful and helpful in showing that we're resolving some of this early stage disease and detected by our quantitative biomarkers. Further exploration of this is warranted. So as far as actionable recommendations, one of the things that was discussed that I think probably is something that should be taken on is our improvement in early detection of airways disease might require the use of expiratory CT scan, which currently isn't part of lung cancer screening. And so we thought that adding the ability to do measurements of air trapping would be extremely useful, because that's probably the earliest biomarker of disease process in COPD and perhaps other disease processes too, like asthma and others that we might want to treat. This idea could tie into Rick's work on defining a combined lung cancer screening COPD protocol, and it might be part of a future version 2 of LCS. This could be further expanded on in terms of detail through this working group that we have now that's generating a white paper on recommended lung cancer screening COPD CT protocols that are inclusive of emphysema measurement. For example, we could add the suggestion of air trapping into that to expand upon that work. And that's what we had coming out of the breakout. So stop there and allow discussion.
Thank you very much, Sam. Any comments, Raul?
Well, I think Sean did a phenomenal job covering every element. I totally agree. I think the primary points were the huge opportunity in risk stratification, trial enrichment. I think the opportunity also of implementation through creating a network of prime sites where some of these recruitment quantitative strategies could be rolled out. I think it's also a very appealing concept and something that we could see if there is traction there. And to me, finally, this notion of putting a little bit more of a focus on airway disease or early identification of airway disease. We talk a lot about CAC, we talk a lot about emphysema today, or this in this year and prior years, but I think airway disease is where some of the therapeutics in COPD are heading to through traits like mucus plugging that are evident on CT scanning, and we are not commenting on that now. I mean, and I think that could be a missed opportunity to identify this disease activity or disease activity in the airways that are one of the primary drivers of COPD progression and evolution, as well as asthma. As Sean was saying, asthma is one of the other conditions we probably also won't touch upon. So I think there's many opportunities there to build from what we are discussing in a very concrete way. So yeah.
Yeah, Sean, I really appreciated the completeness of your report. I was wondering though, in terms of your issue of reducing costs, which makes a lot of sense. Have you heard David Marin discuss his trial design for PCORI for his CAC study?
I have not heard that. I know about PCORI very peripherally, so help me out.
So Patient-Centered Outcome Research Institute, it's been ongoing for a number of years, and they do health services research in the past, or pragmatic trials, or whatever. And what he's submitted and now is getting feedback, has gotten feedback and is resubmitting, is a trial to use 30 centers or so, if anybody remembers this exact quote, to accrue like 20,000-30,000 subjects who are undergoing annual screening, and they're going to look at their coronary calcium in the context of those annual screenings to look at mortality outcome over a period of time. And the reason why they did that trial is because of discussion with NHLBI. NHLBI allowed that they were not going to fund an NLST for coronary calcium, and they encouraged them to use some other kind of novel mechanism. So he came up with this idea of studying this longitudinally, CAC outcomes longitudinally, in a screening population, a lung cancer screening population, as a PCORI trial. And it seems like that's a very attractive model to think about. What's the analog that you could potentially insert to look at pulmonary disease in that fashion with whatever, correlative analyses you wanted to do?
Air traffic could be an example where we would focus in on that to see how well it's predictive of early disease progression.
He has a publication of that study design if you wanted to see it.
We'll take a look.
I might have it. If I have it, I'll ship it to you.
Thank you.
Thank you very much. Other questions? We've narrowed down to really the hardcore. Any other additional concerns, opportunities?
Well, I do.
Sure.
I am thinking about your idea of the expiratory scan. This is really an interesting, because, you know, on the one hand, it goes against the idea of screening. You know, you're screening and now you're gonna, but on the other hand, you know, you could envision a process where it's kind of worked into the process, where the patient's still on the table, you're not doing it on everyone. You have sort of an AI read right at the moment, say, this is a candidate, something like that. And then, you know, you instantly get it. And the reason I'm bringing it up is I've had a very similar discussion with my friends in the cardiac world, where we've been thinking about, you can get chamber, you know, all the chamber sizes and whatnot on a low dose scan. Well, what about those patients where you're worried about cardiac, where you want to get an ejection fraction? And some of the newer techniques where you could just get a second quick scan and get it at systole and diastole, and you could get an ejection fraction. And you know, it's kind of the same idea, where, you know, if there's something abnormal, trigger the next step automatically. So in that regard, I'm really starting to like this idea. You'd have to come up with all the criteria for what would trigger it. But, you know, you know, you could extract a lot of additional information here.
That is a very interesting concept, because in the past we talked about bronchiectasis, and you have done some work with that. So those could be the evidence that you see on the expiratory scan that of airway disease that could trigger the expiratory scan. The other comment on that it maybe is more still untested, but the fact that in the AI world that we live on, having that extra information could also empower lung cancer detection and protection, because it has been shown that the ventilation of it's a lack of homogeneity of the ventilation pattern indeed induces or can be precursors of lung cancer, also kind of the elastographic element. So I think there is another piece of information that that could empower also the power of the screening. Obviously, once you have someone there, obviously those techniques, tools have to be tested. But I mean, there is kind of an opportunity as well to empower.
It's a step beyond screening. You're kind of moving it into almost a diagnostic realm at the same time.
It's true,
Which
but
is kind of-
but is the kind of this wide
Yeah.
integration you were talking about?
It's a very interesting, you've got to set up those criteria for when you can move almost automatically.
Yeah.
Another concept here, I think, is that generative AI I've seen some papers that are essentially trying to convert the inspiratory CT to an expiratory CT, right? Where they've trained on sets where those both inspiratory and expiratory have been acquired, and used the texture features that the model is detecting at inspiratory to predict the expiratory result. And some of those look very promising, in which case we wouldn't have to do the expiratory if those were robust enough. And it might be worth testing that out in the lung cancer screening population.
We were talking last night briefly with Raul and I about the concept of the lung parenchyma as a sensor of environmental exposure of a lifetime. And thinking about the accretion of all the deposition of tobacco and combustion products, free radicals and whatnot. And looking at it biologically from a perspective of host response, the inflammatory response, and what were the consequences over 10, 20 years or whatever. And this might, contribute to a biological construct of your endocytes, your endotypes. Because, you are what you breathe.
Jim, you have a very good comment from an audience member. Can I read it, or do you want to read it?
No, go ahead, please.
This is from Mathis Conrad, to everyone.
Yes.
I believe a combination of prevention and treatment and screening via collaboration with pharma can be useful. More specifically, the problem that prevention has, as in not being regarded as important as it is without visible results, similar to environmental catastrophes where the prevention never directly shows the impact.
Yeah. Right. That's where I think sensitivity of early biomarkers are absolutely necessary. And that's why air trapping, I think, could be useful in that it may be more apparent in early disease. Well, it is known to be more apparent in early disease. And that could be responsive, right, to relatively low risk therapies like, deliver inhalers sooner, for example, and see if it reverses the air trapping signal. And that infers perhaps that we're resolving the early disease process and perhaps stabilizing any future potential progression and exacerbations. But obviously you have to look at outcomes to prove that.
Yeah, but I think one of the possibilities in this intersection is incipated secretions, incompletely aerated lung, stuff like that. Looking at individuals with those things as a function of physical activity. Because, walking may be interesting because it, the cardiovascular exertion of whatever. But it also may be that walking is also pulmonary toilet. It's also oxygen, it's driving airway cleansing.
Yeah.
And clearing those secretions and stuff like that. And you guys got biomarkers that look at that stuff. And that link to physical activity is pretty obvious in a way. And if we could build on that, it'd be very interesting.
We have Dr. Nagabi is once.
Yeah, I wanted to see if you could comment a little bit on this multi-step or stepwise protocol that we would start with a basic non-gated, for example, for CAC. If your calcium is found, then we don't need another gated. You're just detecting disease. But if it's zero, you would do a gated. That was the discussion that we had prior to our New York Academy of Medicine conference last September. And now I just heard from Dr. Fine on expiratory. First question is, do I have to do inhalatory and expiratory together again, or just one add-on expiratory?
Just add on to one expiratory.
Just the add-on, yeah. You wouldn't have to do it together. Yeah.
So you get the base one, which
I see. So you're saying in the follow-up, the longitudinal. Yeah, I would say you need to follow up, right? Because you're going to want to tell whether or not air trapping is resolved or not and persist or not.
for the follow-up, you would have to do both if you're doing follow-up. But in the first session, you got the baseline and your AI says this person, just like David was saying, we measure chambers. If the chambers are in the borderline, say 70, 75 percentile, then we say, we should get your ejection fraction. And we do that easily. We just get your base one, and then we added a 30% cardiac phase for Sicily. And the AI subtracts and gives an ejection fraction. It's all non-contrast. So in your case, we would take the first one and we just say this patient should get an inspiratory scan after that. And
An expiratory scan after that, yeah. Based on, and potentially that could mean that you detected mucus plugging or airway wall thickening or some other feature that was visible on inspiratory that would drive the need for a separate measurement of air trapping as a functional measure.
Yeah, so Jim, I think as part of this program, this never been done before or discussed, at least to my knowledge, in our meetings before. We would come up with, the idea of this Swiss Army knife that we have with chest screening that provide actionable information on multiple front. But that Swiss Army could also be, 2 or 3 different types. The base that covers like 60, 70% or 50%. Then we modify it slightly, and then we cover a much larger population or more in-depth evaluation while the patient is right there. Remember, these are all asymptomatic people. It's going to be very hard for them, for us to get them to a hospital to do an echo. If we can do a quick ejection fraction here, or take him to a more, tertiary facility for other things. Maybe you can comment on that, or maybe we can mature it in our write-up.
More, I think this is the kind of stuff that we have to explore. And this is the kind of thing that if there's an endotype suggesting that this kind of deeper analysis is warranted because of this possibility, I think it becomes very viable.
Yeah, it's still within a screening field. I mean, we're not going to just right there start treating. It's still a screening, but it's a more in-depth screening.
No, it's not quite screening. I'd say it's slightly different. You're moving from screening to diagnostics in a sense. I mean, you're getting a physiologic signal now. I mean, it's really interesting. It's not strictly screening. You've taken a screening and now you've moved to the next step. You're doing almost a diagnostic, but a physiologic diagnostic.
I would call it a physiologic or functional screening, because in order for us to treat, we need to measure and repeat it. And this is probably, at least for ejection fraction, we would need to do an echo. But who knows? Maybe by advancement in CT, because the reason we have not done that with CT is radiation, and we do with echo. I don't know your field, but I think this would be really awesome, because just you just keep adding value to that Swiss Army knife, which doesn't exist today.
And in particular, this is more physiologic information you're adding, which is what makes it particularly attractive.
Ejection fraction is physiologic, it's function,
And mucus plugging becomes part of, becomes a signature. I mean, there's other components to this that could, lead down this direction. Sean, any final thoughts?
No, I think this is really interesting idea. Obviously that it's an implementation question, right? Like being able to quickly endotype on the table is the key step there. And we need an infrastructure to allow that. But I think it's the future, right? This is sort of the way we should be thinking.
Any final comments?
No, I agree. And I think Greg had also some ideas about this adaptive implementation. So I agree, sort of the scanning, but also adding a respiratory scan, because now in the intra-low dose world, it's not a big deal. It's true that is there actionable information there? That is probably the key question, and how that collects.
Okay, well, this is very interesting. Thank you all very much. And we're going to move to the second breakout session, and we have Bruce Pianson.
Thank you very much.
Actuary-in-Chief.
Thank you very much, Jim. We had a straw dog exercise which caused some controversy, so we're going to start by clearing that up if we get on the first slide. So there's our straw dog, and also straw mat, and this is real live AI at work, at least on the right. We think the images on the left are not AI generated, and the one on the right we think is not a real live cat. So the straw man here was for a national triple or tenfold screening program that would be rolled out nationally. We called it a straw man because we were putting together the pieces in a way that we didn't want anyone to feel badly if we, criticized or changed any of the elements of that. So, and let's go to the next slide, please. So the goal, we're calling this a national program, but really it's local. The concept is to have it locally based. Vicki Beckler earlier said programs are either, the screening is either run by a program or it's run by primary care. And that's the kind of concept that we have of the program as a locally operated through the Medicare Advantage world or through accountable care organizations, which cover most of the 65 million Americans over age 65 in the Medicare program. So this is envisioned as a enablement of this thoracic health program that could be bolted on to existing accountable organizations that are accountable in some way for budgets and population outcomes, but on a local basis. So the elements of that are listed here in other sessions, and ours have talked about those, what the clinical model is, how the patient flow works, how the care management works is an important part of it, but there's more. Defining the population that will be served in a way that's other than who shows up at the door. So in this case, we're envisioning members of a Medicare Advantage plan or patients attributed to an accountable care organization. The accountability is defined by those overall entities, whether it's the ACO or the MAO, and accountability for the clinical outcomes as well as the cost impact. And one important element of that is stratifying the population that's going to be served into risk levels. There's based on the needs of each population, where most people are going to have relatively low needs, but there's different needs depending on what gets discovered in the thoracic health program, whether it's a lung condition or lung nodules and so forth. So this is the guts of a program that could be proposed to Medicare's Innovation Center, which goes by the acronym CMMI. I think that predates ChatGPT, so CMMI is the acronym, is the initial. Could be proposed for consideration and development. And what this does is changes the paradigm from one of the existing clumsy, painful referral process, finding the patients, finding the conditions, hoping there's follow-up, to a more systematic approach, and doing that on a national basis, even though it would be operated on a local basis. So I think to progress this forward, this concept, we need details of 1, 2, 3, 4, but we also need to find accountable care organization or a center of excellence for screening that says, yes, I want to do this as part of my ACO or a Medicare Advantage plan that can walk with us to CMMI to raise the idea. My perspective is that, the triple or quadruple screening, or as Mort, I think used the term, that doesn't. That's inevitable.
A dozen today,
Doesn't it?
2 dozen tomorrow.
But it's inevitable, it's gonna happen. And, but we need to accelerate, that process in to make it happen sooner. So that's our, that's our straw dog.
Or straw cat.
Mary, anything further to add?
No, I never had thought about this concept before Bruce kind of started developing the straw dog cat dog. And I kind of,
Smalley,
yeah, I kind of like where all this is going, if all this is combining, it's not just for the patient, it's not just for, the program, but it's also, on a higher level with financial and policy and workflow. So I found it quite interesting.
Well, thank you, and I want to call our partner, Anita McLaughlin, who
Come on, Anita.
Yeah.
Yeah.
Anita.
who has some involvement with GoTo's framework organizations. And having, for sure, some of those framework entities are part of accountable care organizations, because you got 100, well, how many are there? There's
1,000.
that, and so finding some of the framework center of excellence that can envision this as part of their ACO and say, hey, we want to explore this with CMMI, bolting it on to our existing ACO.
Do you think it's doable? I mean, not right now, but down the, working on it. Yeah,
so I think it's a very interesting concept,
yeah, I do too.
but let me just share with you. So I call this thoracic screening and this, that, and the other thing. And I got told that academics say thoracic, no one else does. And that it's chest screening and it's chest CT and stuff like that. And I personally don't care. I like thoracic, but I was told if you want the people's to buy into this, the people buy in, you gotta call it chest. So for what it's worth, take it or leave it. The
And that's what they call it, with some of the other programs like Rescue Lawn Society. That's technically what they call it.
So we had to change it to CHP.
CHP.
I
We
think
can
we
do
still
that.
haven't got the right name yet, because it's more than chess. Yeah, I understand.
Yeah.
Debate it as much as you want. And
I don't have a dog in that fight.
Or a cat.
you were very hepped up and you were very agitated about the idea of leveraging the community oncology centers, COC. Did you have any further thoughts about that and whether that aids or detracts from this?
Yeah, I don't know enough.
Okay, no, that's,
Mm.
yeah, we'll keep talking on it. And you're invited back to Chicago to meet with those people. The other issues, how does this fit with other people's thoughts? Professor
Here's a-
Yankelevitz?
Here's a question, yeah, and
Bruce, or do you want me to read it?
Sure.
This is from Matthias Conrad.
Yes.
By the way, we have the same prevention problem I mentioned earlier with the low workload and cost impact. We did not see what can be saved later in the healthcare system. Radiologists who need to add screening to their workload are not automatically aware of the future diagnosis and the treatment that will not have to happen, all due to the screening. We would need to define a good approximation of savings, workload, and cost and communicate this efficiently. So those are his comments.
Well, Matthias, I think you're absolutely right.
Yeah, yeah.
Thank you.
I would like to comment on this idea. I think it's expanding, we have to get our arms around this as being not lung cancer screening anymore. Because, and then it all starts to fit together, You remember, I've always been against this term incidental finding.
Oh,
Because, they're not incidental. And it's the same here, this idea that it's a whole health idea. Nothing's incidental when you're looking at everything.
and the leading cause of death in the world.
Yeah, and so, and that's what we're talking about. We're talking about making this a scan for general preventive health. And we need to come up with the right name for that. And we're sort of marketing or presenting that to figure out how to get Medicare to get behind this and show that it works. Where we're asking them, in a sense, to pay for this general health check, where you're going to be looking at all of these major things simultaneously. So maybe we get around having them say, we're not going to pay for CAC scoring because you haven't done a randomized trial, or, that we present it as some complete model of everything. Some of the things they're already reimbursed, they're already approved, they already have US, some are right at the border, but are endorsed by different societies. But we come up with a whole presentation of this new era of preventive health that we're moving towards. And that this is the test that allows us to do it. And I think this is, and you've already started talking about metrics for monitoring. You have one for lung, but I think the same exact, you heard me say that we can use the exact same paradigm for each of the tests, just setting different
yield
thresholds. And say that this is what we're doing. This is what the hospital has or has now as its baseline. Here we've introduced the new tests, and we can look at each of these metrics. So I think where I'm heading with all this is, I think that one of the main outcomes of this, and maybe you're heading, is that this should be, we should set up a working group that Bruce kind of leads in some way, or you lead in some way, and we follow up on this. This is big time.
Yes. So, okay. I agree with you. Now, about 5 years ago, CISNET did a model, comprehensive model, looking at the deaths averted due to tobacco cessation since the war on cancer was started. And I forget the exact projection, but I think they postulated that they saved at least 1 million lives based on real bulletproof data. And so one of the things is that that's a great accomplishment and stuff like that. But one of the challenges of it is it's so invisible. People just don't see it, and it doesn't matter because they don't see it. And it happened, and it's nice, but it doesn't strike a visceral chord. And it was kind of that concept that led to my initial slides that said, what's the purpose of screening? And the purpose of screening is not that we all become immortal. The purpose of screening is to prevent premature death. And if reducing premature death is your goal, the first and foremost thing you work on is heart disease. And to just say, I'm not going to do that for $100. It's insanity from a public health perspective. So the reason why I say premature death is because that can be measured. There's, they're talking about deaths and they're talking about before the age of 70. And as I presented as pedo, 80% of this happens between 50 and 70. 80% of these deaths happen in that window that we're screening in. So if we say we're really going to focus on death avoidance, mortality avoidance, premature death avoidance, you can measure it. It means something. It means something. It has enormous societal benefit. And it's such a small piece of the total population pile that it's an efficient strategy. And I think if we did that, we could develop metrics, you know, with the yield metrics and stuff like that, but then actually measure things fairly rapidly because there's a lot of events. And with screening, we have net to catch an enriched population for those events. So I think we got to refine the strategy along the lines of what you just said. Premature death. Now we've got to, premature death can be a technical term. We've got to figure out a more acceptable, you know, communications term for this. Death before your time. Or, you know, whatever.
There's actuarial terms for that, you know. You know, in effect, you have a mortality load from people who are at high risk. And, you know, you have a standard population, and if you're life insurance, you have a select population. And so you can measure and measuring those, as you point out, is relatively easy and fast.
Yes.
You get an actual to expected, and that's relatively easy to do.
And we'll have serial annual data to back check against it. What do people think?
I love the idea.
But I think it's the one of the keys is finding, you know, organizations that already have an ACO that could bolt this on. And hopefully Medicare Advantage plan, but.
I think first we've got to lay it out a little more.
Yeah, we gotta.
And then we figure out which.
Do we need to
organizations-
show outcomes retrospectively?
Yeah, how we're gonna do it.
Yeah.
Lay out a whole
Yeah.
plan and then go to federally qualified centers or.
not-
No, I'm saying whatever we decide to go to,
Yeah.
I'm not saying that's the one, I'm just saying where we decide to go to, we need to have the plan.
Yep.
Laid out. You know, whether it's academic institution or, you know, whatever it is, we'll figure it out.
Okay, well, that's very
But
important.
it's a good,
I think we're out of time for that.
Yeah, no, we're maybe 2 more minutes.
You have to do your
you have
wrap.
your wrap up, Jim.
I have 12 slides to show, no.
That's okay.
I think this has been a very stimulating discussion. I am awed at the quality of the presentations, the cohesion of the panel discussions, the focus, the strategy. So we've been trying to do this, you know, in a productive way for a couple of decades. And I think it keeps getting, I think you think more critically as we've evolved. And I think we're getting close to the cusp of something very important. The backdrop is that this is the single most important determinant of healthcare outcomes. And if we can, you know, premature death. It's an unbelievable driver of all kinds of things, all-cause mortality, whatever. And if we can get a handle on approaching this in a thoughtful, efficient, effective way for 3 to 4 leading causes on the planet. In this country and countries across the world, it can have an enormous impact. So I thank you all for your efforts, for your patience in driving through all this stuff, for prevent cancer and ALA, GoTo for sponsoring this, for AstraZeneca, for supporting this with other commercial sponsors. And thanks to all the people in the Zoom. We'll kind of try to put this together and have some readouts in various forums. We again want to salute a couple things. One is Adrian and Liz, who have done so much to make sure that this was an effective forum. Liz, you want to come by and wave?
She's all the way.
At the very end.
I think she can hear me here, though.
Thanks, Liz.
Thank you, Liz. Again, I want to thank Kyle Meyer for helping us acknowledge the profound contributions of our honoree this year for the Leadership Award, Nancy Obachowski. And Nancy was delightful in the comments yesterday, and it was a beautiful part of this, recognizing pioneers that really made our progress, move forward. And the rest, I think, Bo, do you have any final comments?
Yes, thank you for your leadership. Well, we couldn't do it if you didn't keep us moving along in the right direction.
My privilege, and wish you all safe returns and have a joyous weekend.
Right.